So I'm going to get started right away so that we can keep on time and also leave ample time for Q&A and discussion at the end. There's 20 minutes for this, so be sure to have all your questions ready to go. So I'm so grateful to be here with all of you today to present our symposium on innovations in just-in-time adaptive interventions. I'm going to set my timer, make sure I stay on track. Okay, so we're going to talk to you about today innovations in just-in-time adaptive interventions for mental health. And so mental health issues are highly prevalent across the world, and access to timely and effective treatment remains a challenge for many individuals. There's myriad barriers, including stigma, shortage of mental health professionals, financial costs, time constraints, and even lack of transportation that makes this access to mental health services extremely difficult for certain people. And so the reason we're all gathered here today for tips is that we all believe, I'm pretty sure, that innovations in digital technologies offer promising solutions to these challenges. And so to give you a heads up on how our symposium is structured today, I'm going to kick us off in just a minute talking about conceptual foundations, key components, and new methods for personalizing just-in-time adaptive interventions. Then we're going to have Czyz on building toward adaptive text-based support for parents of youth at risk for suicide. She'll be followed by Dr. Lindsey Potter on the mobile assistance for regulating smoking study. And then Dr. Devin Tomlinson will follow up with a pilot mobile health intervention for emerging adults with regular cannabis use. And then Dr. Shani will close us out here on designing a dyadic just-in-time adaptive intervention for medication adherence. And then, like I said, we're leaving ample time for Q&A at the end that will be led by Dr. Justin Baker. Okay, so without further ado, I want to kick us off on conceptual foundations, key components, and new methods for personalizing just-in-time adaptive interventions. So my objectives here today are first to talk about components of just-in-time adaptive interventions, then briefly talk about the use of micro-randomized trials to answer scientific questions about constructing JITAIs, and then to end the presentation with components of personalizing JITAIs, so a new type of personalized just-in-time adaptive intervention. Okay, so just-in-time adaptive interventions are an intervention design that aim to give protocolized decision support in practice. They leverage digital technology to address conditions that change relatively rapidly, and they're an attempt to provide the right type of support at the right time while reducing burden and habituation. JITAIs use adaptation to target proximal outcomes by using dynamic information about a person to select intervention options over time. And JITAIs have several components, which I want to go through in brief in the next several slides. So a decision rule is typically used to operationalize the adaptation process in a just-in-time adaptive intervention, but of course there's also other ways to operationalize adaptations in a JITAI, such as decision trees and other ways. But in brief, a decision rule uses dynamic information about a person to decide whether and how to intervene, and the decision rules are what link our intervention options with our tailoring variables. And so our intervention options in this particular toy example, where I'm defining proximal outcome for this particular example as next day substance use. And the idea is that if we are delivering proximal support to affect next day substance use, that this will sort of accumulate over time to help with distal smoking cessation. And so here, the two intervention options in this example are to deliver a prompt or not to deliver a prompt, focused on some sort of support for smoking cessation. So an example might be to leave the situation until the temptation to smoke has passed, or call a supportive friend. Talking about what is stressful can help you feel better. So this is the intervention option. Next, we have tailoring variables, and here in this particular toy example, I'm using the word risk as our tailoring variable. This might be a single variable, it might be multiple variables that indicate risk for substance use, so things like having a high urge to use a substance or being in proximity to other people who are using substance use. And tailoring variables provide us with the information used to determine which intervention option to offer. And so in a just-in-time adaptive intervention, these tailoring variables are things that we're measuring relatively frequently, and they're what allow us to have this dynamic information about somebody to make our decisions about which intervention option to offer. And the way we make that decision about what to offer is through use of levels or thresholds of these tailoring variables. And so these thresholds differentiate between conditions in which one intervention option should be offered over another. So in this particular example decision rule that I have on the screen, we see here that if risk, so risk is our tailoring variable, is equal to high, then intervention option equals send a prompt. Else if risk is not equal to high, then our intervention option decision is to give no prompt. And then the last component are decision points, which trigger the adaptation process. So in this particular toy example, our decision points are once per day. And the decision points are the points in time in which intervention decisions should be made in practice. Okay, so why do we need JITAIs? One reason is that they improve the overall, or they're thought to or attempting to improve the overall effectiveness of the intervention because they're trying to provide tailored or personalized support based on how somebody is currently feeling or what type of context they're in. The second one is that they're aiming to improve the overall resource efficiency of the intervention. So by not providing people with interventions when they don't need them, potentially we're decreasing the likelihood of habituation or even decreasing burden, right? Whenever we try to intervene on someone, that comes with a burden. And so if we're being strategic about when we're intervening, we can potentially reduce burden and the likelihood of habituation. Okay, so we have talked now about components of just-in-time adaptive interventions. So let's now move briefly into how do we actually answer scientific questions if we want to construct a JITAI to be implemented in practice. So here's 2 scientific questions we might ask in the process of optimizing a JITAI or constructing a JITAI to deliver in practice. One is, on average, is it beneficial to deliver versus not deliver a prompt? And the second one is, under which conditions would delivering a prompt be beneficial? So in this figure down below here, we have risk, our tailoring variable, and then you can see equals high or equals not equal to high. That's our tailoring variable with our thresholds. And then we have this owl with our question marks, right? We don't actually know what to do in these situations. And so here we can use an MRT to figure that out. And so an MRT, or a micro-randomized trial, is an experimental design that sequentially randomizes each person to an intervention option at each decision point. And these micro-randomizations can occur hundreds or even thousands of times across the study period. So in this figure down here, instead of assuming our tailoring variable, I have here measure candidate tailoring variables, and then which could include risk or indicators of risk. And then we're micro-randomizing people at each decision point. In this example, you see a 0.5, so that means we're micro-randomizing them with equal probability at each decision point to either receive a prompt or not to receive a prompt. And then you see our black arrow, and then we measure our proximal outcome. In this case, if we're interested in next day substance use, perhaps we would measure that the morning or the evening of the next day. And so the key here is that we're micro-randomizing because we don't actually know yet whether it's beneficial to deliver a prompt and the context or states in which it's beneficial to deliver a prompt. And so, like I said, these MRTs are useful for addressing these types of scientific questions, and the analyses that we do happen offline once the study is complete. So this is a key bit to remember that's going to come back later in the presentation. And so one type of analysis that we can do is a main effect analysis to answer the question, on average, is it beneficial to deliver versus not deliver a prompt or message? And we can also conduct moderator analyses to examine under which conditions would delivering a message or prompt be beneficial. And so this is what would then allow us to identify our tailoring variables, such as risk or indicators of risk. And so if we consider some hypothetical results, let's say that from our analyses, we collected all of our data, we analyzed our data, and we found that on average, sending a prompt is beneficial for next day substance use, particularly when risk equals high, but not when risk is not equal to high. And so these offline analyses would then provide the information we need to construct a decision rule, so what we see in the top right, for a JITAI that can be implemented in practice. So the top right is our decision rule, so if risk equals high, then intervention option equals prompt. Else if risk is not equal to high, then intervention option equals no prompt. And then if we move down to the JITAI example figure down below, this is showing that these are decisions that we're making repeatedly over time for individuals to try to affect our proximal outcome of next day substance use with the goal of accumulating these proximal rewards or increases, or I guess in this case decreases in next day substance use that might better set someone else or someone up to achieve the distal outcome of smoking cessation. Okay, so that was micro-randomized trials in a really brief nutshell. But now, to end out the presentation, I want to talk about components of personalizing JITAIs. So there's another intervention design that's connected to the JITAI called a personalizing JITAI. And we have 2 talks today that will go a little deeper into specific domains where these are being studied. And so JITAIs, as I've talked about earlier in this talk, are motivated by the need to address conditions that change rapidly with the goal of increasing the relevance of the intervention to the specific person and their experiences. And personalizing JITAIs are taking this vision one step further. And they're called personalizing because they add another layer of adaptation to achieve personalization. So in a standard JITAI, the adaptation is operationalized by decision rules, which is where we're using dynamic information about a person to decide whether and how to intervene. And then in a personalizing JITAI, we're adding an additional layer of adaptation where we're actually adapting the decision rule itself over the course of the intervention. So we're using dynamic information in this case about individuals' intervention responsiveness in different states and contexts to learn how to update the decision rule so that through the course of the study, we're hopefully optimizing the decision rule itself to be as effective as possible as the person experiences the intervention. And so here, by personalization, I'm talking about an aspiration to increase the personal relevance of an intervention with the overall goal of increasing intervention effectiveness. So this relates to this idea that interventions are more effective in cases when they're not a one-size-fits-all approach. And so, like I said, personalization in a JITAI occurs via adaptation, operationalized by decision rules, but these decision rules are static across the intervention period. Whereas personalization in a personalizing JITAI is doubly adaptive. So we're both using adaptation operationalized by the decision rules, but also adapting the decision rules themselves. And so in brief, in a personalizing JITAI, which is basically a JITAI with an artificial intelligence algorithm, such as a reinforcement learning algorithm, we're first observing at each decision point, we're first observing a participant context, so this might be their level of risk, and we're inputting those values, so the levels or thresholds of the tailoring variable, into the optimization algorithm, which helps us make a decision about what action or intervention option to offer. And then after we do that, we get some feedback, which is in terms of measuring our proximal outcome, so this could be next day substance use. And then that feedback, or the person's proximal outcome, is fed back into the learning algorithm component so that we can learn. So if somebody is in a state of risk, is it actually beneficial to deliver a prompt or not to deliver a prompt? And so we're learning at that point, or we're learning continuously throughout the intervention, and learning is expected to improve decision-making for given states or state combinations across the intervention period. So our risk might be a multivariate state that's defined by urges, proximity to others using substances, and other components like that. And so a key feature of these personalizing JITAIs is that unlike a standard JITAI where the decision rule is deterministic, so if this, then do this, here now we have a stochastic decision rule where if, for example, risk is equal to high, then intervention option equals deliver a prompt with probability 0.6. Else, if risk is not equal to high, then our intervention option is to not deliver a prompt with probability equals 0.7. And you'll notice here these don't add up to 1, and that's okay, because these are separate states. And what we're trying to do here is by probabilistically delivering these intervention options, this is what allows us to learn throughout the course of the study. If we only delivered prompts when someone was in a state of high risk, we wouldn't actually be able to learn in an online way or during the course of the study whether that was more effective than not delivering a prompt when they're in a state of high risk. And so here's another schematic of this where you can see now that the probabilities are changing across decision rules. So if we look at particularly risk equals high, right, we see at this first decision point that the probability is 0.6. It gets updated to 0.62 at the next decision point, and then updated again to 0.65 at the next decision point. And at the beginning of the study, we're constructing some sort of warm start, so that's our best guess at what the decision rule should be. And as we accrue more and more data on participants throughout the intervention, the prompts are then delivered increasingly with probabilities that are guided by their accrued data, and ideally more and more personalized to their experiences of the intervention. And so, to summarize, we have a just-in-time adaptive intervention, which is an intervention design that's particularly useful if you want to use dynamic information about a person to decide whether and how to intervene in order to address conditions that are changing relatively rapidly. There's also a related intervention design known as the P-JITAI, which is a JITAI plus an online artificial intelligence algorithm, such as a reinforcement learning algorithm. And this is also an intervention design, but has continual learning that's happening through its implementation. And this is if you want to use dynamic information about a person to decide whether and how to intervene. And additionally, if you want to allow the decision rules themselves to adapt during the intervention. And then finally, we have this micro-randomized trial, which is not an intervention design, it's an experimental design that's particularly useful if you have scientific questions about constructing a JITAI or a P-JITAI. So I have 2 more slides. My first one is gratitude to my collaborators, particularly Billy Nahum Shani and Susan Murphy, who were very helpful in constructing these slides. And I also want to point you to this QR code for the Data Science for Dynamic Intervention Decision-Making Center's website, where we have several statistical software components that you can use, experimental design applets, learning resources, and even workshop information. So I'll give just a second if anybody wants to try to snag this QR code. And then finally, I want to give another upcoming, or give a nod to the upcoming presentations again. So next up, we're going to have Eva Czyz, who's going to be presenting on an MRT to inform a JITAI for increasing proximal well-being for parents of youth exhibiting suicidal behaviors. She'll be followed by Dr. Lindsey Potter, presenting on an MRT to inform a JITAI for increasing engagement in self-regulatory strategies in adults attempting to quit using tobacco. Then Dr. Devin Tomlinson will present on a micro-randomized trial with an embedded reinforcement learning algorithm to inform a P-JITAI for increasing proximal engagement in emerging adults who want to reduce their cannabis use. And then finally, we'll have Dr. Shani presenting on a human-centered design study to inform a dyadic P-JITAI to increase mental well-being and positive relationship dynamics in adolescent and young adult caregiver dyads. And then we'll wrap it up with a discussion and Q&A led by Dr. Justin Baker. So, thank you all so much.
All right, hi everyone. Really nice to see you all here. So in my presentation, I'm going to talk to you about a recent study that our team conducted, focusing on how we can support parents and caregivers of youth who are presenting to emergency departments with suicide-related concerns. And in this presentation, the design we had actually is a bit of a hybrid because we used a more traditional RCT with an embedded MRT design. So just to give you a sense of building off of Dr. Benson's presentation, that there's sort of multiple different ways that one can leverage these really exciting methods. I would like to acknowledge the many, many collaborators who were involved in this work. This work was conducted at the University of Michigan, as well as the funding, which came from the National Institute of Mental Health. I'm not sure how many of you are aware, but I'm suspecting some of you are aware that suicide risk is a huge concern for youth in the United States. It's one of the leading causes of death. We're also concerned about rising rates of non-lethal suicide attempts and suicidal thoughts in this population. Paralleling these increases in risk, many of you who are practicing and are working in healthcare settings are probably aware that there's a huge volume of youth who are coming through emergency departments seeking services for mental health, behavioral health related concerns, and a large portion of these are related specifically to suicide risk. So in the last decade or so, there's been a 5-fold increase in suicide risk-related visits in youth specifically. And that's the population that we were interested in. A challenge, of course, is that once someone visits an ED, it doesn't mean that the risk stops. And in fact, many youth continue to be at elevated risk for recurrent suicide attempts, ideation, and related crises. In a way, the ED could potentially be a place where we can leverage sort of the high volume of kids seeking services to provide interventions with the goal of supporting families and adolescents in terms of reducing suicide risk-related concerns. The challenge, of course, is that EDs are already quite overwhelmed serving this population. So the interventions should ideally be adjunctive, brief, kind of low resource, and very accessible. That's the goal. And that was the framing from which we're coming from. In terms of pediatric patients, ideally, we should involve caregivers or parents in a more systematic and evidence-based manner. And so the reason for that, many of you who are working with families can appreciate that parents are frequently tasked with carrying out suicide prevention activities that we would recommend following a crisis, so things like helping with lethal means restriction, reducing access to whether firearms, medication, or other lethal means to the youth, attending to potentially to suicide warning signs, seeking appropriate services, supporting the youth, helping the youth with coping. At the same time, we know that parents are feeling quite overwhelmed and distressed following a crisis like that, and also express low confidence in being able to support their adolescent and suicide prevention activities. So that's really the framing, the motivation for the work that I'm going to present that we were hoping to address. We're seeking to develop a low-cost, low-burden intervention delivered via text messages for this population, and we thought about this stemmed from a lot of focus groups we did with families, with parents. We conceptualized this intervention having two components. So one focusing on, and both were delivered to the parent. So how can the parent support their adolescent, and how can the parent be encouraged to follow through with some of these suicide prevention recommendations in terms of things like lethal means restriction, supporting the youth, supporting coping, supporting safety plan use. And the second component focusing on parents' own well-being, given that parents are reporting high levels of stress, negative affect, which can reduce their capacity to be available to provide support to the youth. And it's with the second component, the parent-centered component, that we were seeking to develop a just-in-time adaptive intervention to address the time-varying well-being of parents, specifically with our proximal outcomes being parental stress and positive affect. I mentioned before that we sought a lot of feedback from parents in terms of developing the intervention. So the messages were vetted, if you will, with multiple stakeholders, including parents and experts and providers, to try to develop something that parents found acceptable in terms of the content, the messaging, the language around how this information was provided. But I'll zoom through the actual design, so you can see this is framed as an RCT, but here on the right-hand side, we had an embedded micro-randomized trial. So we involved 120 adolescent parent dyads. Remember, this is a R34 pilot, so we were not trying to be overly ambitious, but recruit enough people where we could learn something. Parents were randomized to 3 groups: control, or a 6-week intervention. And we had almost like 2 different intervention arms. So one arm only had the adolescent-centered messages delivered once daily, delivered to the parent around providing support to the youth. The second arm had this additional component, the parent-centered messages, which had the embedded MRT. And so each day for 42 days, so this is 84 micro-randomizations, we provided a message, or we randomized parents to either receive or not receive a message in the morning, in the evening. We selected these times because these were the times that parents were more likely to be around their children to try to determine if and when these messages are most impactful. We surveyed parents twice daily, in the morning and the evening, to collect our tailoring variables, but also our proximal outcomes following randomizations, and in addition had sort of the more traditional assessments that happened 2, 6, and 12 weeks after discharge from the ED. The focus was feasibility, acceptability, of course, and whether we had any promising impact on mechanisms of change that we were interested in, youth outcomes in terms of suicide attempts in a preliminary fashion, but also for this MRT, we're interested in eventually informing a just-in-time adaptive intervention to try to determine if the messages were having some kind of a hint in terms of our interest in the parental stress. Very briefly, because I'm worried my time is winding down. In general, parents found the intervention to be to be satisfied with the intervention. They perceived it positively. 95% would recommend it to other families. We weren't really surprised. We really vetted these messages almost in a very obsessive manner to try to like really get them right and not shame parents around, are you doing this or not doing this? In terms of on the RCT side, so the between group analyses, we did find some promising findings in terms of our mechanisms of change. We're interested in whether parents are actually following through and implementing these recommendations in terms of youth safety. And we found that parents post-intervention 6 weeks and at 12 weeks, relative to control, parents who received the texting intervention did in fact engage more in these behaviors that we're hoping they would. They did not feel more efficacious in doing so, so we did not impact beliefs. This is at the top, what's grayed out. But it seemed like the intervention probably acted a little bit more on motivating behavior or like cue to action type mechanism. We were happy that parents did engage in these behaviors. So whatever the mechanism was in this case, in a very preliminary way, youth whose parents received the texting intervention did have, in fact, fewer suicide attempts 3 months following ED discharge. This is preliminary. We were not really powered for this outcome, of course, in our 34 study, but it's sort of hinting, it's trending in the right direction. In terms of the MRT itself, so this is the very busy slide, but I want to remind you in that right top corner, we were randomizing families, or parents rather, twice a day to receive or not receive messages that were focusing on their own well-being. And I didn't really say much what that meant, but these were coping strategies, sort of self-care nudges, testimonials from other parents, things that parents told us in focus group they really wanted to see that would be helpful to them in terms of helping their own well-being. And our proximal outcomes were measured following each randomization, parental stress, and positive and negative affect. This arm of the intervention only included 40 parents, so this is very piloty, but we had over 2,000 observations at the within-person level. And so what we found is when parents were randomized to receive these small nudges related to their own well-being, we did actually find statistically significant impact on the next observation over the course of the 6-week intervention. So kind of going back to what Dr. Benson was talking about, that we're looking at marginal effects over the 6-week period. Parents reported lower stress, less negative affect, and more positive affect. So all of this is looking promising in terms of the MRT portion. Because I only have 2 minutes, I'm going to try to wrap it up. In general, we found the intervention was feasible, acceptable. We looked at 2 levels of analyses, sort of this between group RCT level and then within person MRT level. Both levels showed promising findings in terms of the mechanisms that we were interested in. I'm presenting this also to encourage those of you in the room to think about these MRT and experimental designs and just in-time adaptive interventions in a flexible way. Like for us, we were also interested in between level effects or between group effects. So just thinking about an example where you can really incorporate these really innovative experimental designs within more traditional, quote unquote, trials as well. And our next goal is to do a full-scale trial, which we are gearing up to begin in the coming year, where we will be able to, in a more definite fashion, determine and whether these findings actually replicate in a large sample, but also in a multi-site study. So, we were very happy to partner with a really supportive ED in our institution, but it doesn't mean that this translates in other communities, particularly in a more kind of community-based hospital settings, where we'll be trying to see whether this actually works. And in terms of the MRT, to try to see not only if but when these messages may be most impactful. We will be collecting data, not just from parents, but also from youth, to try to see if there's some youth-specific tailoring variables that we could learn about in terms of the intervention, the messages being helpful or not helpful. Happy to stick around for questions, but also feel free to reach out if you would like to connect later. Thank you so much.
Okay, thank you so much, Libby, for the introduction and for having me. So I'm Lindsey Potter. I'm an assistant professor at the University of Utah, and I'm going to be talking about the Mobile Assistance for Regulating Smoking project. This was an NCI-funded U01 that Dr. Billy Shani and Dave Wetter were MPIs of, but very much a team effort, which is why the slide. I'm not going to spend a lot of time on the background. I think everybody here knows that tobacco is a huge public health burden. There are a lot of tobacco cessation interventions out there. Self-regulatory activities are key components in many of these. So things like mindfulness, behavioral substitution, these are things that can help people change their behaviors and cognitions in support of quitting. But engagement with these is a major barrier. People don't engage with these types of activities. So what can we do? The goal is really, can we help improve the efficacy of interventions by increasing engagement in real-time, real-world settings? So I'm going to talk about the results of this study, which we abbreviate and call MARS. You have this nice little planet here. MARS was a 10-day micro-randomized trial to investigate whether, what type, and under what conditions a prompt to engage individuals in self-regulatory activities increases engagement and reduces vulnerability to lapse. The study was overseen at the Center for Hope at the University of Utah, very much during COVID, so remote or in person, but mostly remote. And I have our inclusion and exclusion criteria here, but in a nutshell, we were recruiting adults who smoked at least 3 cigarettes per day and were motivated to quit. So participants in this study attended 3 visits that occurred 3 days prior to their quit date, on their quit date, and 7 days post-quit. During this first visit, we gave them a study smartphone that was pre-programmed to administer the MRT. And across these visits, we also, everyone received brief tobacco cessation counseling, answered questionnaires, and participants received 6 weeks of nicotine replacement therapy. So on each day of the MRT, participants were micro-randomized 6 times. So first they answered 2 questions, one about cigarette availability and one about negative affect. And then they were immediately randomized with equal probability to no prompt or a prompt for a self-regulatory strategy. And on this arm, we were equal probability to a prompt recommending a low effort strategy or a prompt recommending a more effortful strategy. An hour later, participants received an EMA, and this is where we assessed our primary outcome of proximal engagement and self-regulatory strategies in the past hour. We also asked questions about behaviors, cognitions, contexts, of course, behaviors, one big one here being lapse. So together we call this a block. So there were 6 of these blocks across each day of the MRT. So our first aim was to test whether prompting versus not prompting increases proximal engagement with self-regulatory strategies, and we hypothesized that prompting versus not prompting would indeed lead to greater proximal engagement. The second aim was to test whether prompting to engage in a low effort versus more effortful strategy would increase proximal engagement. And we hypothesized that prompting to engage in a low effort would lead to more proximal engagement than a higher effort, and I'll talk more about that later. Our third exploratory aim was to examine moderators of the association between prompt versus no prompt on engagement. And finally, we conducted exploratory analyses to examine the association between engagement and self-regulatory strategies in the past hour and lapse. So like I said, engagement was operationalized, primarily self-reported. So we had 3 EMA items that asked about engagement. So if a person responded yes to any of these items, they were considered to have engaged. If they answered no to all of these items, they were considered not engaged. We tested various different moderators using stable and dynamic factors. So we used responses to that 2-question survey that happened prior to micro-randomization. We used information reported in the EMA, as well as at baseline. And we also considered self-reported and tracked engagement using app data prior to the micro-randomization as a moderator. And then finally, we operationalized lapse in 3 ways. So we use our EMA item asking about substance use since the last assessment, and we constructed a variable to look at cigarette use alone, a tobacco product, as well as any nicotine-containing product. Okay, so for hypothesis 1, we use the estimator for marginal excursion effects, which is a generalization of regression that can ensure unbiased estimation when you have time-varying intervention prompts. This model was extended for AIM-3, so we could look at the interaction between the candidate moderator and the treatment indicator. And here we use complete cases among eligible decision points between days 2 and 9. The reason we did this is because days 1 and 10 coincided with the first and third study visits, so that impacted the opportunity for people to receive 6 microrandomizations on those days. But as I list below, we did do several sensitivity analyses, one of which included days 1 through 10. So I'll talk more about these as I get to the results. And then finally, we had several time-varying and time-invariant covariates that we had in our model. And then for our exploratory analyses, we used generalized estimating equations to examine the concurrent and lagged association between engagement and lapse. Again, using complete cases on days 2 through 9 with several covariates. We started with over 800 individuals who were interested in participating, and after accounting for people we couldn't contact or were ineligible, people who didn't show up for visits, pilot participants, and people who had very few EMAs or microrandomizations, we ended up with 99 people in our analytic sample. These were mostly females, nearly evenly distributed between Hispanic Latino, non-Hispanic Black, and non-Hispanic White, and about 44 years old who smoked about 13 cigarettes per day. And I didn't put it, but the income was hanging around $45,000 per year annual income, household income. So now to the fun part. The first hypothesis that prompting versus no prompting would lead to greater proximal engagement was supported. So prompting to engage versus no prompting resulted in 11.2% greater likelihood of proximal engagement. And an important thing here is the sensitivity analyses. So these results were robust when we considered days 1 through 10, when we considered EMA non-completion, which is where we assessed our outcome, to correspond to no engagement, to correspond to engagement. We repeated these using multiply imputed data, and these results were also stable over time. The second hypothesis was that prompting to engage with a low effort would lead to greater engagement versus a higher effort. So we had a quite lively debate about the hypothesis when this study started, and Dr. Nahum Shani gave me permission to say she really pushed for this hypothesis. The reason being that there is a pretty big difference in the level of effort required between the low and high effort, which I'll show you. But this hypothesis was not supported. So we actually found that prompting to engage with a more effortful strategy versus low effort resulted in 18.4% greater likelihood of proximal engagement. Again, these results were robust to all 3 sensitivity analysis, multiple imputation, and they were stable over time. In terms of moderators, there wasn't a lot happening here, but one thing that we did find is that engagement in the prior block moderated the effect of prompt versus no prompt on proximal engagement. So when we operationalized prior engagement as self-reported engagement using the EMA in the prior block, we found that when no engagement was self-reported in the prior block, we saw a 42% greater likelihood of proximal engagement. And then we also looked at engagement, prior engagement using self-reported information and tracked engagement. So we actually are able to go in and look at data from the app to see, did someone actually click into any part of the MARS app? And again, we saw that when there was no prior engagement, we saw 57% greater likelihood of proximal engagement. Click. I think I'm frozen. My slides are frozen. Escape? Okay. You're all on the edge of your seats. Should I hit F9? Okay. No. Well, this I only really had one more slide, so I can handle it. Slides are frozen, okay, but I'll let them know. Slides are frozen. Okay, so, okay, this is a test of my memory. Oh, here we go. Oh, no, I did have one more. Okay, exploratory analyses, I didn't get to this part. We looked at the association between engagement and our lapse outcomes, and we found that when participants reported to have engaged, the odds of cigarette use was 31% lower, the odds of tobacco use was 28% lower, and the odds of any nicotine-containing product was 17% lower. And these are for the concurrent models, so meaning that engagement and lapse were assessed in the same block, and our lagged models were not significant. Okay, so overall, we have evidence that prompting individuals attempting to quit to engage with these evidence-based self-regulatory strategies is beneficial, and it's really exciting how robust these results were to all of the sensitivity analyses and multiple imputation, and to see in a full-scale MRT that this really could help people. Contrary to what we thought, the more effortful strategy led to greater engagement. So the more effortful strategy was a 2 to 5 minute exercise that people completed on the phone. It was things like mindfulness, cognitive restructuring, and they really had to spend time in the app to get through to the end of this exercise. In contrast, the low effort were short, what we called quit tips in practice when we were sort of running the study. These were easily implementable, cognitive behavioral things like substitution or engage in positive self-talk. So it could be that people had to spend more time with the high effort, so it was just more beneficial. The other possibility is recall bias. I think that if you did the higher effort, you would remember because it took quite a bit of time and effort, whereas maybe people didn't remember if they engaged in the low effort. And then finally, prior engagement. So when we had no prior engagement, a prompt was beneficial. So this is really exciting because it could mean that no engagement is an opportunity, so you can really re-engage people even when they start to kind of fall off. Oh, my slide got mixed up too. And with that, I just want to say thank you to Dave and Billy for supporting me leading this project and this paper, Jamie Yap, who did all of the analyses, staff and data teams, and then, of course, our funders. Thank you. Ooh, okay.
Hi there, my name is Devin Tomlinson. I'm a postdoc at the University of Michigan Addiction Center, and I'm here to present on a pilot mobile health intervention for emerging adults with regular cannabis use, a micro-randomized trial. First, I have no conflicts to disclose, and I'd like to acknowledge NIDA for the funding of the P50 that funded this work. And I'd also like to acknowledge the team without whom this work wouldn't have been possible. And so first, I want to talk about cannabis use among emerging adults. And so cannabis use actually peaks in emerging adults who are ages 18 to 25. And according to the 2022 National Survey on Drug Use and Health, 26% of emerging adults used cannabis in the past month, and 38% had used cannabis in the past year. Regular use of cannabis, meaning use 3 or more times a week, increases the risk of an individual's risk for negative consequences. An earlier onset of cannabis use is associated with physical and mental health consequences, as well as an increased risk for developing cannabis use disorder. Digital interventions and digital health approaches are nascent for cannabis use among emerging adults, and so just-in-time adaptive interventions provide an approach to leverage this dynamic information to adapt the delivery of the intervention components to reduce cannabis use. And so integration of artificial intelligence into these JITAIs is innovative and could be applied to support substance use interventions. And so today I'll be presenting preliminary data on the acceptability and feasibility of a pilot micro-randomized trial, MRT, called MyWaves, and if you're interested, the design protocol paper is available at this link. And so MyWaves, the overarching goal of this P-JITAI is to help reduce cannabis use by enhancing engagement, and to do that we're using a micro-randomized trial design where participants will be randomized twice daily over 30 days to either receive or not receive an intervention, a message. And so the engagement strategies we chose to use were check-ins, trends, and other app features, these intervention messages, and a reinforcement learning algorithm. And so broadly, here's our conceptual model for the intervention. And so the key intervention components include self-monitoring surveys and feedback, which are thought to act through the mechanism of change, self-awareness, and reflection to ultimately reduce cannabis use. We believe the messages will act through the mechanism of change, future and goal focus, alternative activities, and affect management. And then the personalization algorithm, the length of messages, and the interaction type of the messages, which I'll touch on later, are thought to act through mHealth engagement to ultimately reduce cannabis use. And so I'll go over the MyWaves pilot study design here. We recruited 122 participants who were ages 18 to 25 years old in the US who had recent cannabis use, that is, used 3 or more times a week, and they had some motivation to change or reduce their cannabis use. And this was operationalized as reporting either a 1 or higher on a 0 to 10 scale of motivation to reduce or stop their cannabis use, where 0 is not at all and 10 is very. Participants downloaded the app, and over 30 days they were prompted via app push notifications to respond to a brief check-in survey, which you can see this happens twice a day, so in the morning and in the evening. After each participant completed the check-in or chose not to complete the check-in, the reinforcement learning algorithm would take information about the participant's self-reported behaviors, for example, recent cannabis consumption, and assign the participant a probability, which then determines the likelihood of them receiving a message or not. And so this happened again twice a day after every AM and PM check-in. In MyWaves, each decision point, the reinforcement learning algorithm will use each participant's prior data to adjust the probability of delivering a message to maximize the proximal mHealth intervention engagement. And so in this study, our warm start was 0.5 for each of these, and then over time, the reinforcement learning algorithm could assign the probability varying from 0.2 to 0.8 over the 30 days. So next I'll talk about some of the engagement strategies and features we used in the app, starting with the check-ins. And so the check-ins were these surveys that happened 2 times daily. They took about 3 minutes, and the items assessed included health behaviors like sleep, physical activity, alcohol, and cannabis use, mood, hopefulness, and engagement with the behavior change strategies suggested in the intervention messages. We also wanted to create an app interface that was engaging, so we consulted prior work and worked with emerging adult advisors to assess these features that they wanted in an app. The second feature I want to touch on is the rewards. And so participants were instructed to tap to reveal a small monetary incentive for completing these check-ins. And so this ranged between 50 cents to $3 for completion of each survey. And this was taken from a fixed pool of 60 incentive amounts totaling $60. Participants also had access to view their trends or graphs of the answers to their surveys. So this is an example of cannabis usage over time, but you could change the buttons. You can't see my mouse, but there's also alcohol, sleep, exercise, and stress. Participants also had access to review any of the messages they had received in a message bank, so they were able to go back and revisit any of the messages if they wanted to. And so since the messages were pretty important, I wanted to touch on how iteratively these were developed. And so first, the intervention content was synthesized and augmented from prior work in drafting new messages grounded in motivational interviewing and behavioral economics, among other domains. Then we had what we call a content-a-thon, where RAs and content area experts refined and created additional content for the intervention. We then, as I mentioned earlier, formed an emerging adult advisory board to obtain feedback on the intervention content, design, app interface, and message wording, among other things. And then the finalized intervention content was an iterative evaluation by clinicians, behavioral scientists, emerging adults, and research staff to finalize the intervention content. And so one of the things we want to look at in this pilot is what makes a message engaging. And so the messages participants were sent varied on a couple of factors. So first, the message length. Short prompts were brief messages like sound bites that were less than or equal to 150 characters, or they were receiving long messages, which were more detailed, which were greater than or equal to 200 characters. And these messages also varied on type of interaction. And so the interaction A would be that participants were just asked to read the message and acknowledge that they saw it. Interaction type B would be that they click a link to external content and then acknowledge the message. And so an example of this would be you receive this message, you visit the link, read the link, and then go back and acknowledge that you did that. And the third type of interaction was participants were asked to provide a response within the app by either selecting from a choice of options, as shown on the left, or writing in a response in a text box, as shown on the right. And so in the future, we're interested in examining if these message features, whether the length or the interaction type, influence proximal engagement. And so I have some results on feasibility and acceptability. Unfortunately, no MRT results today, but those will be coming, so stay tuned. We had, as I mentioned, 122 participants who were approximately 22 years old. Over half identified as female, and the race breakdown is right here, where almost 74% identified as white, 10% identified as black, 5% as Asian, and almost 11% identified as multiracial. At baseline, we assessed substance use, and so maybe not surprisingly, almost 90% of individuals endorsed using alcohol at baseline. We had 44% of the sample using cannabis at least daily. 25% used cannabis within 1 hour of waking. Over half of the sample drove within 1 hour of using cannabis, which is something maybe more research is needed on. And then we also had approximately 15% endorsed prescription drug misuse, and almost 20% endorsed other substance use. We also assessed at baseline for psychiatric comorbidities, and so we had a third of the sample screened positive for depression at baseline, 50% screened positive for anxiety, and 59% screened positive for PTSD. And so in terms of feasibility, we had 83% of participants who consented to participate download the app, which is pretty promising. And our twice daily check-in completion rate was 76.9%. And during the first 2 weeks, this was 89%, and in the final 2 weeks, it was 67%. So perhaps some more research into trying to maintain that over the course of the full study. In terms of acceptability, we had a few items that I wanted to touch on. So first, participants were asked how interactive is the app, and 60.2% said the app was just right, and some thought the app was not interactive enough, about 40%. Participants were also asked to state their agreement with the following statement: completing the check-ins twice daily was doable for me, and the majority either strongly agreed or agreed with that statement. Participants were also asked to agree with the statement, I could complete the check-ins in a reasonable amount of time, and the majority strongly agreed or agreed with that statement, suggesting that the length of time that the check-in windows were open for was acceptable. We also have these acceptability ratings of different components of the app, and so overall, on a scale of 1 to 10, where 1 was poor and 10 was excellent, the app helpfulness was rated a 6.2 on average. The Life Insight Graph helpfulness was the lowest acceptability rating, so those were those trends I showed you, which were 5.4. The incentives was the highest rated feature at 8.1, and then we asked participants to rate on a scale of 1 to not at all, to 10, definitely yes. How likely would you be to recommend the app to others? And participants said a 7.1 on that scale. We also asked participants if they received the right number of messages or if they prefer more or less, and we found that 62.5% of individuals in the study thought that they received the right amount of messages, while 16% preferred less and 21% preferred more. So that's future work to dig into too. And so overall, we found that the app was feasible and acceptable, and so the future work that I hope you all stay tuned for is to evaluate the effects of these messages on engagement, so looking at the MRT results and hopefully presenting those soon. And then this work really provides preliminary evidence for a future larger scale efficacy trial, which I'm excited about. And I have some references, and I'm happy to answer any questions over email or during the Q&A, so thank you.
All right, so I'll be presenting a project where we're designing a dyadic just-in-time adaptive intervention for medication adherence. We're calling it ADAPT HCT. In a sense, it's a little bit of moving back in time compared to some of the other projects. This is a pilot project, pretty much in the development phase. So I'll go into a lot of the details in the process that led to developing what we need the app to do, how the app would do it, the reinforcement learning algorithm, and all the other components that were described a little bit as a more developed thing in the previous projects. It's not responding. No. There we go. I want to recognize the team. Sangwon Choi is the lead PI on this project. It's a pilot project. We're also working with Susan Murphy and Ziping Shu, who are developing the reinforcement learning algorithm that goes into this dyadic P-JEDI. We also have people from D3C, Billy Nahum Shani and Pei Yao Hung, who are key collaborators, as well as I want to recognize Alex Piogius and Karen Lyons, who also do work in a related field with regard to cancer patients and relationships, dyads within these kinds of contexts. I also want to point out that we benefited a lot from participating in brainstorming sessions at the D3 Center. These brainstorming sessions over the past year really helped us identify and find the right solutions for different problems we were running into as we were learning more about the context, about the patients, and so on and so forth. So it's an amazing resource, and I don't think this project would look the way it is without having access to that. So our objective is to promote medication adherence among adolescents and young adults, AYAs. And they're undergoing treatment that's preparing them for transplant. So the focus is on the medication that they're taking. And what's interesting here is that they're not managing their medication on their own. They usually have at least one parent who is heavily involved in their treatment and constant care. So it provides us a really good opportunity to develop a P-JEDI that focuses on dyadic personalization. So it's a dyadic P-JEDI, not just individuals, but also a dyad. Technology is not liking me today. There we go. All right, so our study population, these are young adults, adolescents and young adults are preparing for bone and marrow transplant. We're looking at the first 100 days where they're supposed to take a medication that's supposed to reduce the risk of post-transplant rejection. And one of their family caregivers is usually heavily involved in their treatment. And I want to kind of just give you a little bit of context. This is medication that they're taking twice a day that makes them feel really bad. So there's a lot of aversion from the side effects and a lot of drive to not really take their medication regularly. The medication itself also affects them, make them very weak and tired. So forgetfulness beyond the baseline is also an issue. There's also schedule and routine disruption. These kids are not in school as usual. They're in and out of school, so the regular routine gets disrupted, which further affects their ability to stick with a routine with regard to medication. And then this is also an age where they want to develop autonomy and agency. And they have a parent, well-intentioned, that is trying to help them take their medication constantly, not just reminding them, but helping them and supporting them in things such as setting up their pills in pill boxes, helping them arrange and develop different strategies, constantly nagging them. Did you take your medication? Did you not take your medication? And this really creates this heavy burden on the AYA, their parent, and their relationship. So P-JEDI here can be really useful because in this context, we're trying to use a P-JEDI to develop an adaptive algorithm that would intervene in real time, affecting both the AYA in remembering to take their medication, the parent who is part of their support system, and also to support their relationship. And with supporting the relationship, one of the innovative things we're doing here is we're leveraging a collaborative game. So we're using gamification to provide an incentive for them to collaborate in a way that is not necessarily tied to the medication. So kind of avoiding the elephant in the room. And even with all these things in account, we're still looking at a distal outcome of maintaining their medication adherence over time. So we did a few focus groups initially to get a better sense of the context. We asked them, what is a typical day with regard to taking medication? We talked with families that have already gone through this process. So they know a lot about what their day looks like, what are the different challenges, how they keep track of the medication. They have amazing strategies that they've developed. What happens when they have to skip a dose because they need to? What happens when they miss a dose because they forgot to? How do they deal with that balance between the parents wanting them to take their medication and also the need to manage themselves? We're really surprised by their openness to engage in new technologies that would help them manage their medication. They saw a lot of value in that, and that was really encouraging. The other thing was that they've already had all these effective strategies. So it was very clear that we don't need a system that would substitute for alarms and reminders. We need something that would be running underneath that would help them develop good routines and good habits and good capabilities. So one of the things we tried to extract from these focus groups is identifying the things that affect the AYAs, the parents, and the dyads that we want to address. So for the AYAs, it's forgetfulness and aversion, and the desire for developing autonomy. For the parent, it's a concern about adherence, and also the need to let their kid develop autonomy. And then on the dyad level, it's the toll that this relationship has as a result of dealing with medication the whole time. So from a conceptual model perspective, let's start from looking at that distal outcome. If we look at the distal outcome, we want to get the AYA to adhere to medication. Our proximal outcome, it's not just adhering to medication, they have to take 2 doses, one in the AM and one in the PM. As far as our mechanisms, there are 3 levels at which we operate here. The first is at the child level, the AYA. We want to address their forgetfulness and aversion and autonomy and agency. For the parent, we want to provide supportive messaging that would enable them to be more effective at cultivating autonomy and agency with the teen. And then at the dyad level, we want to provide them opportunities for them to collaborate in a way that is not necessarily tied to taking the medication. So we have 3 levels here. The AYA, the parent, and the dyad. This is what the PJITAI needs to manage. So it's not just 1, it's 3. 2 individuals and their relationship. Now, the intervention options that we have are also tied to these 3 levels. For the teen, we're looking at medication reminders, and for the parent, positive messaging. And for the dyad, the collaborative game, the opportunities to play the collaborative game. Now, as a PJITAI needs to decide whether to provide these intervention options. And this happens at different timescales. So these decision points happen for the medication reminders. This is twice a day in the AM and the PM. For each of them, there is a chance for a reminder to be triggered. For the parents, the messaging is once daily. And then for the game lasts a whole week. So the decision points for the game, whether it's a game on week or a game off week, happens at the weekly level. That means that now our PJITAI has to deal with 3 levels and also 3 different time scales. And in order to feed all of that, we need to collect data and measures that would help the decisions be made by the RL. So the medication, if it's logged as taken or not, affects the AYA. The interaction with previous messages by the parent affects provision of additional messages to the parent. And then the dyad component is affected by low reported relationship quality in the app. So if we take all this into account, we can see how going backwards from the distal outcome all the way down to our conditions under which things would trigger helps us identify the different things that the PJITAI needs to work with. To make all that work, we have Susan and Ziping who have been working with us on developing the reinforcement learning, the RL algorithm. Now, as Dr. Benson explained, PJITAIs analyze data in order to use the reinforcement algorithms to give the participants the type of interventions that they need in a given time. But it focuses on a single person or a single level. In our case, we have combinations of both individual and dyads, and we also have different timescales. So in that sense, we need to now go from focus on adapting the decision rules for a specific individual to look at 2 individuals and their relationship. And then we're also not looking just at one single timescale. We're looking at something that would need to address 3 different timescales, each mapped to a different level. So a dyadic PJITAI will govern the analysis and adaptation of decision rules on multiple levels, so those are the levels that we talked about, and on multiple timescales like we see here. With the remaining time that I have, I'd like to go a little bit into some of the insights we got as we developed some prototypes and mock-ups for the app. So it's nice to look at all the things that the RL needs and the different concepts we're trying to look at, and how do we use that to generate ideas for developing an app. And the approach we use is using very low-tech sketches. So this is not final screens. These are hand-drawn sketches that we show the people that we're talking with. We talk with the parent and one of the teens, and we get them to provide feedback. And because it's hand-drawn, beyond the fact that they say that, wow, that looks really neat, make the app look like that, which was surprising, they're also more likely to pick up a pen and tell us, move this over here, or I like this, or I don't like that. Saves a lot of money too, because you don't have to write a single line of code to get any of these, and that's also a really important component. I want to highlight one of the insights that we got out from this process. This is a prototype screen of the medication log. So just showing them the medication log the AYAs immediately recognize this as, wow, this is great. I can keep a log of the medication I've taken, and it's also wonderful because mom can see that I've taken my medication and she's gonna get off my back. Mom also looks at that and says, like, this is great. I can monitor what the kid is doing as far as taking their medication without being too intrusive. So because they see value in this, they're gonna come to this page. While we have them here, we can piggyback on that to provide messaging, daily diary assessments, and also try to encourage game engagement. And as far as the game, just to give you a sense of how we're going about this, given the population, what we're dealing with, we wanted something that is a low time commitment and something that they could also do when they're fatigued cognitively. Just sitting with some of these kids, during the interview, you could see how their ability to engage declines over time. The medication is really difficult. So we want to find something that they could make progress even if they're not really feeling up to engaging fully. So what we did is low effort game, guessing words and phrases was something that was more accessible to both the parents and the teens. We decided to use clues. So if you let the clues show up, the game will solve itself on its own, addressing the issue of I can't engage in this. But if I want to accelerate solution, I can engage in guessing. So for example, here you tap this, you get the letter P, and then the letter P would get populated in the puzzle. So here you have a phrase, a very simple phrase. You can see that we've assigned one word to each of the members of the dyad, one to the teen, one to the mom. And in this case, if they didn't want to engage, they could solve this word pretty easily. But if they do, they can try and guess it and type in, oh, this is pancakes. They type in pancakes, oh, I got it right. So there also is a sense of achievement when they solve something and a sense of achievement by making progress. Now the interesting thing is when we showed it to these dyads, the first thing they said was, oh, I can help him out. I'm really good with these puzzles and he sucks at it, or vice versa. So they immediately identified that they can collaborate outside of the app, and that's what we wanted them to do. We wanted to engage in collaboration. It's not a competitive game. So they immediately started to latch on to how we can use this as a way to achieve these things easier. So if the teen is feeling more fatigued, mom can step in and vice versa. So as far as next steps, we're working in multiple directions. The main thing is really identifying the frequency of measurements and how we collect that data in a way that's not obtrusive, not overwhelming from the different targets, in order to feed the RL and let it do what it needs to do, and then continue to refine the application to be able to support this type of data collection and the interaction that we need. And we'll be piloting this next year, so really excited to see how this turns out. And thank you very much, and glad to answer any questions later on.
Yeah, so I don't know if you guys want to just put chairs down there, or we're supposed to. Yeah, that's probably easier. Excellent. Well, I can sort of see you from here, or should I come down there? I don't know. All right, I'll just stay here for now. So great presentations. I'm sure folks in the audience are having some questions as well. So as you have questions, we'll just ask folks to use the mics. I want to just start by, I was really interested in, obviously with JITAI, the focus is on adaptive timing, having the best timing for things. But there were some presentations talking about how do you adapt the content of the prompts, especially I think in the Mars project. Lindsey, you mentioned kind of the low effort versus the higher effort coping strategies that folks were using. Maybe just Lindsey, for you, and then for other folks, I was interested in kind of what you thought about the high effort versus low effort, whether you thought that was the determining factor versus, you mentioned kind of the elaboration, sort of the high effort one might have been more kind of memorable or whatever. I'm also wondering if it was just maybe more fun or more engaged. I noticed it was like more colorful and things like that, but I guess the question for the group is also just, is there a way to really think about using like an adaptive design to find content that people latch onto, where it's sort of like over the course of a design, you can kind of progressively provide people with the content that they're gravitating towards, or whether you've thought about that. So I don't know, Lindsey, if you want to start it off.
Does this work? Yes. Okay. So I think one thing that I didn't say for the sake of time was that the 2 questions that we asked about cigarette availability and negative affect, that was actually used to tailor the content of the low effort message. So that's just one detail to give people more context. I think why we saw the result that we saw, the low effort is, I think, just less engaging, and I think it's really hard to know if people are gonna see a tip that says, you know, if you're stressed, take a walk with a friend. Like, it really would be hard to know if we're actually giving them something that is low effort to them, is tailored to the right, their responses. Like, if they're experiencing negative affect and cigarettes are available, there's 4 buckets of messages. So I think that one was just really challenging, and it's really, they read it and they could do whatever they want. So it's just hard to know what was going on there. I think that the higher effort is just really, my opinion, is helping people sort of move through waves of urges, like things that are really prominent when someone's going through withdrawal. Like, most people who lapse within a week of quitting. So I think that high effort really did help people engage in strategies that help them get through those really tough moments. And the other thing about this is the 3 EMA questions about engagement. The 3rd item said, did you engage in something that was not recommended by Mars? I think that one is really interesting because we could look at over time, are there differences in people endorsing that specific item versus the 2 questions about the recommended strategies? Like, maybe we can start to parse out, oh, are people sort of learning what works for them? So there's a lot we can do with the objective app data and those EMA items. I don't know if that answers your questions, but.
Yeah, I mean, I think it kind of gets to the question, just sort of the core of the JITAI, which is like you're trying to find ways to engage people that they really want to gravitate towards. And so I think what we found in more informal ways is that, the timing of it is important. So even for something like an EMA, putting that EMA at a time of day that someone is actually likely to respond is what's one of the early ways that we found we had to actually tailor it to each individual. But then some of the other things we've found is that some of the EMAs, people just don't resonate with the question.
Yeah.
And so they don't really want to answer it because it's like, well, it's kind of aversive. I don't hear this speaking to me. Whereas, so we'll then, in some of the studies, adjust the language in the question based on what words they prefer. And so I guess I'm kind of trying to get at that a little bit of like, have any of you sort of explored really trying to tailor the exact words or the exact, using images versus words or sounds or something like that, just to provide an intervention that somebody is like, oh yeah, I like this one more than the text only or something.
Yeah.
Did you find some of that? I know you had text length, right, Devin, in yours?
We have the different interaction types and then the lengths, but we haven't parsed out which was more effective. But I think it could vary by individual too. Kind of speaking to if the high effort resonates more with you, then maybe the low effort or the interaction type where you're writing out a response maybe is more engaging, and so you remember that and are more likely to engage again.
Yeah, Daniel, you want to?
I can speak loud.
Well, we're recording it, so if you don't mind.
Can't speak loud. Hello. Is this okay?
I think it's on, yeah.
Okay. No, I was just curious, what are some common methodological issues with especially the time varying kind of JITAI? So if you have, attrition, that could introduce confounding, and is that any different than in normal randomized control trials? And then can people learn to kind of game their responses to get certain interventions? And can you alleviate any of this with causal inference methods like G methods or case crossover design or stuff like that?
I can give one comment. I think, and this is one take on your question, is that in terms of from a statistical perspective, right, I think one of the things, I think you did this in My Waves too, where you had lots of different message bins. So one inclination, right, would be to analyze all the different types of messages. You know, maybe they're characterized by different things or different self-regulatory strategies, right? But lots of times you have to sort of have this trade-off between burden and sort of the depth of insights that you can get. And so I think oftentimes statistically it's harder to be able to get enough instances of different self-regulatory strategies or different types of messages, which is why oftentimes, at least in current implementations, it's defaulting to prompt versus no prompt rather than digging into specific types of prompts, right? Because if we were prompting people 10 times a day for 100 days, right, that's burdensome, right? And we're going to start getting more and more attrition, which then has its own statistical considerations. So I think that's one concern, is how you get the type of data that you're really interested in a feasible way that, you know, gives you the type of insights that you want to get based on the stats that are possible to conduct. So that's one way to answer that question, that it's difficult, and, you know, that's not really an answer, but it's certainly a nuance that I think people are working about, trying to balance the complexity with burden.
So great work, everyone. This has been really good. And one of the questions I want to, maybe it's a two-part question, but I'll try to keep it to one. Years ago, long time ago, I was doing nicotine replacement therapy. And what I did was I wanted to know if tailoring on content versus the visuals and, like, you know, race, gender, age, those type of things. And what I found was that we got message persuasiveness and engagement based on the visuals and, like, tailoring on age and all that, but the content is what affected intention to quit using cigarettes and intention to use the nicotine replacement patch. And so it was, but you had to engage the user to keep them on in the content to then deliver the messages which spoke to them, and we, like, tailored, you know, all these different things. We were, like, tailoring on, like, the different messages. Now, one of the things that I want to ask you guys about is, are you testing to ensure that your messages are equal? Like, as in equal in emotionality, equal as far as engagement. And one way to do this, you can just use MTurk, right? You can just pre-test all these messages and get them rating on different things so that you can ensure that when you're putting the messages out that they're, like, head for head, semi-equivalent. And you may find that some people like more emotional, some people like more this. Anyone doing anything like that?
Well, I can speak in Mars, our buckets of messages. We had, you know, the 4 quadrants of messages based on those 2 questions that we asked. And then we had quadrants within quadrants, because there are people on our team that were really interested in how, like, motivational messages may impact how effective the low effort is. So we basically had some low effort in this bucket that had, like, a motivational stem, and some that didn't. We have not yet dug into those data, but it's definitely something that we could start to do, to speak to your point.
You can also go back. So if you already have those messages, you can now go back and have other people code them for those things and then run analyses that way.
Yes, definitely. It's a really great idea. We haven't made it there yet, but that's a great suggestion. Do you guys have anything to add?
I'm just going to add, so, like, in our MRT, I really struggle with this, sort of how to construct these messages and how to tailor them while making it very simple. For our context, we were thinking about the EDs that would eventually provide these messages, and text messaging is a little bit more challenging than, like, an app-based delivery. You know, one of the reasons why we had so many parents rate these messages is to kind of help us weed out some of the messages that were just not appealing. But what I did find is that while some messages appealed to some people, they really irked other people. And it's like, I think at some point you just have to accept you can't please everyone, but at some point, like, if your bank of messages is sort of trying to somewhat appeal to different people, and we try to kind of mix messages that were more simple and kind of what we called standard messages, with messages that had more content, like links to additional resources, messages that had images. But one simple way we try to bucket ours is that we started with sort of, buckets that kind of targeted different content. So from like coping strategies to testimonials to more kind of encouragement. And we sort of thought about it a little bit more conceptually, where we tried to provide the quote unquote more simple messages in the morning, because we thought parents are less likely to have time to actually absorb the strategies wherever they were. And the more kind of complex, like more time-involved messages in the evening, where parents presumably have more time to engage in the message. But that's also an assumption that does not apply to everyone. The nice thing about text messages, I'll say, is that the messages people can go back to them at any time. And so when it's delivered, right, you don't have to engage in that message in that moment. We did look at, actually, I didn't talk about these results, we looked at moderators based on time of day, which sort of corresponded to sort of the more complex or an easy message, and time of day did not really moderate whether the receiving or not receiving the message had an impact on these outcomes. And so who knows what that means, but it's a struggle actually to develop the messages to really not. Also, our messages were delivered using motivational interviewing context, so we were not assuming that what we're providing, suggesting to you is going to be helpful to you per se. It's like a very nuanced nudge and a recommendation without telling you what to do, or that we know that we assume that what we know is applying to you. But that was the most challenging thing about the whole thing, is like developing the message bank.
I'll just stand here. It's a little less awkward. I think one of the things that really strikes me about this work is just how practically useful it can be for clinicians and ultimately clients, patients. So I guess one of the questions that I have, and this is really for everyone, but I think, Guy, your work especially goes here, which is, do you think that there are some potential opportunities to begin implementing these tools in clinical practice even before they've started to show sort of statistical findings on those distal outcomes? You mentioned, the clients, the youth sort of found it was useful. They didn't have mom over their shoulder because they could see it in the app. I think that's likely to be true for other domains as well, but I just wonder, as you start doing these kinds of studies for the purposes of, ultimately publishing and looking at, psychological effects, are there opportunities to begin implementing these in real-world clinics before that?
So I'm actually really glad you asked that question. So I wear two hats. On one side, I'm a human factors person, but I'm also at the business school at Michigan. And one of the things that really fascinates me is how can we take these ideas so they don't end in publication, and this is a great grant, but how can this survive beyond that and be something that we can all implement and use in our day-to-day. I think one of the key things is developing a framework and foundation for the tools. I mean, any one of us wants to start from scratch to build one of these things. It's a tremendous cost. Development time is very expensive. The technology moves all the time, and we can't keep up with that. One of the key things is having, imagine a library of all the different components that you need, so that any one of you would want to run one of these studies, you could pick up a module that would say, oh, I want to include this, this, and this. And then you can focus on creating the content and things that are relevant to your sphere of knowledge. And one of the things that the D3C they're working on is, I think it's called Justin, which is basically creating a repository of modules that could implement JITAIs and PGTIs and dyadic PGTIs as well, and maintain that and make that something like a public good that we can use for the wider community. Because I think, we can immediately see that when we show these to participants, they see value in it. You want to grab it and take it out there. If you had components that you could put together that are validated and tested, then I think that is much closer than it is right now.
I mean, just medication adherence obviously is an issue. I mean, in pediatric populations, probably for a range of conditions, I can imagine, even when you don't have a tissue rejection outcome, you might find that just that module alone saves parents all kinds of grief or whatever. But.
Oh, they wanted it to cover all their medication. And we're like, we can't do that yet.
Yeah. Great.
And just to continue on that kind of line of thought is that there are likely to be very large individual differences. And if you had a library, you could show your participant or your patient, here are the different options, which one is more appropriate for you, certainly for children, different ages and so on.
Yeah, involving participants in designing these systems is, it seems like, why aren't we doing this more? And because programmers are needed, and that creates that barrier.
Yeah, and maybe just along those same lines, you mentioned, several of you mentioned bringing stakeholders into the process of designing these. I heard a lot about bringing patients, caregivers, not as much about bringing the clinicians in the loop. So I'm just curious about, as we think about these tools really being a way ultimately to get patients doing more of what they're supposed to do in treatment that we think, from a paternalistic side they should be doing. How are you guys thinking about bringing in clinicians into that process? I know some of you have already mentioned it, but.
So the pilot that I mentioned, in our next step, we're doing a hybrid effectiveness implementation trial where we're trying to, while trying to learn about, is this actually effective, we're trying to learn from more system level stakeholders, so healthcare systems, right? Like we're trying to talk to people within the health system, from physicians to nurses to social work staff who are talking to these families, but also people who are in the information technology field, right? Because we're thinking about a lot of these interventions, there's technology, but we're not maybe necessarily thinking, is this actually feasible for the health system or whatever it's delivered? Like, what do they need in terms of attending to issues of, even things like cybersecurity or security? Like, what features is a given platform needed, and is this something that is sustainable? So our next step is to try to sort of try to learn about how would this actually be implemented in your health system, what barriers do you foresee, who are the decision makers, and how can we get around the barriers? I think that's really critical. In addition to talking to the consumers sort of being defined very broadly, from patients to providers, but also to these decision makers and leaders in a given system.
There's another line of work in the D3C that Billy Nahum Shani is spearheading on hybrid experimental designs and multimodal adaptive interventions that aims to look at synergies between digitally delivered components and human delivered components. And so I think that's a key way as well about how the clinicians, the types of interventions that are going on in the clinician office versus the types of interventions that can be digitally delivered can act synergistically. And so I think that's another key way that science is being advanced, although not something that we talked about today.
Thank you. Very interesting presentations. I'm Venkat Bhatt, based at the University of Toronto. So just thinking about the different interventions and just-in-time interventions for what? For the person in a particular environment, in a particular disorder, for a particular specific outcome. And I was also thinking of one or two of your presentations gave the perspective that you can start off with rule-based systems, but then you can gradually make them data-driven. When you're going from rule-based to data-driven systems, there may be the opportunity for you to collect specific information, environmental information, particular disorder information. So I'm wondering how you're building an ecosystem for that, where you would actually collect these individual pieces of information so that it's just in time for those things. My concern is that a lot of this will not be generalizable. So if you don't collect all of those pieces of information and then say that it's for that particular outcome, you might not get a model which will actually replicate.
I think I can try to answer that. I mean, in the context of tobacco cessation, you're talking about, I'm thinking of your question in terms of like contextual, other factors in the environment. So like one concrete example I can think of is location. And, there's a lot of evidence that proximity to tobacco outlet in real time impacts urge, for example, and how close you live, all of those things impact cessation outcomes. So thinking of just other pieces that we can collect in real time and then trigger a certain type of prompt, that is one concrete example that I can think of in the context of our work that we've started to do that in our observational studies. We haven't integrated, a location-based prompt in an MRT, but I think that we have the infrastructure and the team to collect it, and we could certainly start to do that in these designs, yeah.
I think this is also part of the usefulness of the micro-randomized trial design, right? Because we aren't tailoring from the get-go, right? We're measuring all sorts of candidate tailoring variables, right? And then conducting analyses after the end of the study to really be able to identify where the signals are. And I think, especially when you're doing formative work, being really broad perhaps in the types of candidate tailoring variables that you're measuring so that you can inform the construction of an optimized JITAI rather than maybe only using intuition or things like that to form these decision rules. So I think there's opportunities that way too, to measure more than, a really broad array of things, and then get more and more specific through the intervention optimization process. Anybody else wanna? Okay. And I think with that, we are at time, 3 minutes over, sorry about that. But thank you all so much for being a really amazing audience. Thank you, Justin, for leading us in Q&A, and thank you to all the speakers as well for sharing your work with us, and looking forward to hearing updates as you proceed. Have a great rest of your day.